Yeah, thanks so much for coming in. Welcome to the 41st edition of the Archives Public Lecture Series, produced by the Archives at NCBS. My name is Venkat. I'm part of the team at the Archives at NCBS, which is a public center for the history of contemporary biology in India. The series that we do is more of a history of ideas series that we've been running for a little over 3 years now. And as some of you who have been here for these in the past would know, these forums to try and get people who've done an extraordinary body of work to sort of talk about how they've thought about some of the issues that are going to be discussed and contextualize the present in some measure, if possible. So it is my pleasure and privilege to invite Thomas today to give his talk titled Wiping Polio Off Spaceship Earth, the Hope and Dream of Disease Eradication. Thomas is the author of Polio, the Odyssey of Eradication, published in 2018, which is longlisted for the Wellcome Book Prize 2019. And he's also the author of 21st Century Plague, the Story of SARS, which was published in 2004. He's an adjunct associate professor at the University of Hong Kong. His research work focuses on risk communication during infectious disease epidemics, the role of media in communicating risk and infectious diseases, and global health security. He's been a consultant for the World Health Organization and other international organizations on risk communication. And prior to joining the University of Hong Kong, Thomas worked for 25 years as a journalist. He's a former editor and deputy editor of the South China Morning Post in Hong Kong, and also spent 13 years as a foreign correspondent in Sri Lanka, the UN office in Geneva, and in London for the Hindu. Thomas and I have been speaking about this particular lecture that he was going to give. We were hoping to have it in person. We were just thinking it might happen, but we probably will have to wait a little bit more. But we're very honored to have you here, Thomas, and I'll hand it over to you. Thanks so much again.
Thank you so much, Venk. The honor is entirely mine. I'm so glad to be able to share my thoughts on this idea of disease eradication with all of you. Hopefully, we can get a discussion going as well. And you also mentioned contextualization, because I think in terms of the discussion that is going on now about whether the current pandemic, whether SARS-CoV-2 is going to become endemic, is it something we're going to have to live with, or is it going to disappear? With most of the opinion favoring the idea that this is going to become endemic. I think the whole idea of eradication, endemicity, and our relationship really with disease-causing pathogens, I mean, something that we need to reflect on. And so I hope this sort of example from both the past, but also the continuing presence, will provide you with some food for thought. So without further ado, I will share my screen with you and begin the presentation. Okay, going to full screen. Is that good, Venkat? Is the
yeah, we can see this.
Right.
Perfect.
Okay, great. So the title, Wiping Polio Off Spaceship Earth, actually is not mine. It's not even Venkat's, but it belongs to a very remarkable person, actually one of the greatest leaders that the World Health Organization has known, and that is Halfdan Mahler, who was Director General of WHO from 1973 to 1988. He was a Danish physician. And he, in fact, began his career with WHO, working on the tuberculosis program in India in the early 1950s. And then he went on to become head of the WHO. And he retired in May 1988. And one of the last things that public speeches that he gave prior to his retirement was to the World Health Assembly that year. Now, the World Health Assembly is the annual gathering of member states of the WHO, which is basically all the countries in the world bar a couple. And they meet once a year, usually in May. And the 1988 meeting was also Mahler's farewell to the organization. He was a much loved figure, and he had been Director General for 3 consecutive terms, longer than any Director General either before or since. Now, he bowled a bit of a googly there. In one of his last speeches, he suddenly declared, what about having the guts to eradicate poliomyelitis from spaceship Earth by the year 2000? I think we should do. I think it's doable. And the WHO's member countries, of course, Mahler has asked for this. It's his farewell speech. They all agreed to this. Now, why do I say it was a bit of a googly? And I'll come back to this a little later. Mahler had built his leadership of the WHO around the idea of primary health care. And his biggest achievement really was the Alma Ata Declaration on primary health care. And this was seen as a move away for global health, a move away from the practice of addressing single diseases like smallpox or before that, yellow fever, malaria, and rather looking at health in a slightly more holistic way and addressing a whole bunch of health issues at the same time, including the need for stronger health systems, more hospitals, more clinics, more doctors, and so on and so forth, and really building public health from the ground up. So that was primary health care. And through most of his director generalship, smallpox was actually eradicated during his first term in office. And he had not launched it, but it was eradicated during his first term in office. And he, of course, congratulated everybody. But at the time, he also said, this is the last time that the WHO is ever going to be involved and spend so much resource on eliminating just one disease. In future, we're going to spread our money from the ground up on a much broad, to strengthen health systems and look at issues like primary care. And that was Mahler throughout until this last speech. And I still don't know. I've not had any explanation of why he made this abrupt U-turn. There is some speculation on who persuaded him and so on, and I won't deal with that. But it really was a googly. The WHO, the World Health Assembly immediately said yes. And by the way, polio eradication was not even the biggest item on the agenda that year. There were a whole bunch of other issues. HIV/AIDS was much bigger, the election of the next director general, and so on and so forth, budgets and all of that. So this was just a small item, one of the many resolutions that were passed that year. It said, we will try and eradicate polio by the year 2000, and we will consider this a gift from the 20th to the 21st century, right? A fitting gift from the old century to the new century. Now let us consider, and this was what really fascinated me. But as you've probably gathered, I'm not a medical person or even a scientist by profession. I'm a journalist by profession, but I'm deeply interested in the natural world, and more interestingly, in the ways that the natural and the social world interact, basically the relationship between man and microbe. So I was fascinated by the idea of eradication, first of all, and that's why I decided to pursue and write a book on polio eradication. So what exactly is eradication? Now, a widely used definition describes it as the reduction to zero of the worldwide incidence of infection as a result of deliberate efforts. Intervention measures are no longer needed. Now, this is a fairly ponderous definition, but let's unpack it and see what it really means, especially for polio. Reduction to zero of the worldwide incidence of infection. That means 0 cases of polio as a result of deliberate efforts. But once it gets to 0, intervention measures are no longer needed. So we take efforts to get to 0. Once we get to 0, That's it. The disease is eradicated. So what exactly does this mean? No intervention measures are required. Well, and this will be obvious to all of you. It means that the polio virus
Sorry, everyone. We seem to have lost Thomas. Just going to try and get him back in a moment. So thanks for your patience. Hang on. Hi, everyone. Just got off the phone with Thomas. Turns out his internet's completely collapsed, as he says, and not entirely sure what happened there. So he's going to try using his phone to see if it's going to work. So thanks for your patience. Stuff like this happens. So again, really apologize on behalf of the speaker and on the campus. Hopefully it should get sorted in a few minutes. Thank you.
Apologies to all. I lost connection, but it appears I'm back. So let's see. I have no idea what happened, but the whole thing just collapsed. Anyway, the internet is back on me. So deep apologies to all of you, and let me continue. Can you hear me? Venkat, am I?
Yeah. We can hear you.
All right. Okay. So without further ado, let me. And is my screen visible?
Yes. Thank you.
Yeah. Okay. So I was talking about the scale of this ambition. Basically, the polio program was aiming to drive to extinction this virus, invisible to the human eye, resident at that time in the guts of millions of people. And how is this going to be achieved? I found that question fascinating. So that's really what got me interested in this whole venture, if you will. Now, how is this to be achieved? The polio virus has no other known host than human beings. So clearly, if all humans were immunized against the virus, then there would be no more susceptible hosts, and the virus would be driven to extinction. So that, in one line, was what the polio program is about. So how was this immunization to be achieved? Now, in 1988, in fact, from the 1960s onwards, there was a cheap, easy to use, and seemingly effective vaccine, that is the oral polio vaccine, developed by Albert Sabin. Now, most adults at that time, through most of the last, the first half of the last century, had already been exposed to poliovirus. And therefore, the strategy really, and since they were exposed, they were immune. And so the strategy really was to immunize every child in the world under the age of 5 against polio, because this was the only immunologically naive group. The vaccine was to be administered to every child 2 times a year in mass vaccination campaigns. And another advantage was that since the vaccine was oral, it did not require trained healthcare workers to administer. And it was thought that even the poorest countries should be able to achieve this goal. So it was also seen as this really egalitarian form of global health. It is not an intervention that only wealthy countries or countries with well-developed health systems and a good health workforce would be able to achieve. This was something that the whole world could achieve. So in a sense, this was the vision, the spirit, if you will, that was moving the polio eradication program. Now, initially, the campaign did really well. So this was a map of polio endemic countries in the world in the year 1988. And as you can see, it covers most of the world, barring North America, parts of Europe, not even the whole of Europe, and southern, that's Brazil and, Argentina and Chile and Australia. But in the rest of the world, polio was endemic. It was there. Though I think it's important also to note that in 1988, which was peak polio, there were only 380,000 cases of paralytic polio that were recorded. Now, when I say only 380,000 cases, I don't mean to diminish this. This is 380,000 children who've been paralyzed. But if you put it against the wider background of other diseases, the morbidity and mortality of other diseases, or even other childhood diseases, polio was rather small. It was a terrible disease because it crippled a child. But in the larger scheme of things, it was just one, and not even the largest, of the kind of disease risks that children across the world faced. So this was what the world looked like in 1988. Now, since then, polio it's reduced by 99%, the incidence. It has disappeared from most of the world, but it has not been eradicated. And we remember our definition of eradication, which is basically no virus, not a single exemplar left in nature anywhere. The virus continues to circulate in Afghanistan and Pakistan. And more worryingly, and this is something that I will come to a little later, the oral poliovirus vaccine, though it was extremely effective, did have a flaw. It could create, if you will, the vaccine virus could in effect take a life of its own and spread among communities, reacquire virulence, and cause polio. And that is what has been happening in many parts, in many countries across the world, particularly in sub-Saharan Africa, across Central Africa, and as well as in Pakistan, Afghanistan, Southeast Asia. You get these cases popping up, clusters of cases popping up. Now, the problem is that as long as the virus circulates anywhere, particularly the wild or natural poliovirus, it can be reintroduced by travelers into polio-free countries. So to use a widely used slogan, cliche even, no country is safe until every country is completely safe. The original deadline for eradication, as you will notice, it is now the year 2021, has been pushed back time and time again. And to be honest, it's not clear when it can be achieved. Basically, $1 billion a year is being spent now by the polio program just to stay where it is, right? And the polio eradication campaign's monitoring body, this is an independent monitoring body, has described the campaign as being in crisis and has said that the goal of eradication is under serious threat. So what has gone wrong with this dream, with this grand ambition? Okay, I'm going to come back to this map a little later, but take a look. You remember the 1988 map with red painted across most of the world? Now that red has shrunk. And the only two endemic countries now are here, Afghanistan and Pakistan. And you can notice that there are two kinds of dots on this map. You have the red dots and you have the green dots. The red dots are caused by wild poliovirus, the poliovirus as it exists in nature. And the green dots, which you can see are more numerous and also geographically far more dispersed, the green as well as these yellow ochre dots are far more widespread. And let's get rid of this. And so this year, as you can see from the slide, this year is an unusual year. So Pakistan has got 9 cases of wild poliovirus, Afghanistan has 4. But this has been the year of COVID. So both vaccination and surveillance, disease surveillance has completely stopped. So we really don't know what the virus is doing. And it'll take a while before both immunization campaigns as well as surveillance campaigns can resume. So right now there's a sort of curtain, this veil of ignorance, if you will, on what is actually happening there. But the wild poliovirus is clearly circulating. And as you can see, all across here, vaccine-derived polio cases are also increasing. So Nigeria, as of 3rd August, has 154 cases this year, Ethiopia 23. Afghanistan has had 211 cases of vaccine-derived polio. And so this is the tip of the iceberg, because as I said, nobody really knows what is going on, but this is a huge issue. And especially the fact that the virus derived from the oral polio vaccine virus is now spreading and causing disease. So these are huge issues that remain. So we will come to that bit by bit. Now, what went wrong? Now, as part of my part of the research for my book, and here's the cover of the book, and I promise you this is the first and the only plug for the book that you're going to see or hear. This came out in 2018. And earlier, I had traveled to Pakistan and Nigeria to find out why parents were refusing to vaccinate their children against polio. One point I need to make is that, one of the I think the biggest achievement of the polio program and the Indian government and the Indian health system has been eliminating polio from India. And so by the time I started writing this book, India was already history, though I have chapters in it detailing the long struggle to actually bring the number of poliovirus cases down to 0. But Pakistan, Nigeria, and Afghanistan were still they were polio hotspots. So I traveled to both of these places. I'm going to show you some. So this is a village in Kano, Nigeria. And I was traveling with people from UNICEF. UNICEF and WHO work jointly together on polio eradication. So I was a group of officials or people from UNICEF kindly said I could accompany them. And so we went to this little village outside Kano, in Kano, the province of Kano in northern Nigeria. And there's a vaccination campaign going on. And you can see out here, you can see these blue clots are really the vaccinators. But I was more fascinated by the surroundings and what this kid was doing. So this is down here. I don't know if you can see the point to the marker, but down here, this is basically raw sewage that is running down the street. The children are barefoot. They're playing around in the sewage. So clearly clean drinking water was an issue, sewage was there. And so clearly there's a whole universe of health issues that are, that surround this community and similar communities in the midst of the polio program. I then went to a nearby primary healthcare center. And this is basically all that I saw. Initially, to be honest, I didn't know whether this person was alive or not. So I asked the attendant there, he said, no, don't worry. This is just a bad case of malaria. And people like this come all the time. We put them on drip and by tomorrow he'll be fine. He'll go back home, right? And so I thought this was also striking. Both the appearance of this primary healthcare center, the way it looked, the complete lack of any infrastructure, and the fact that there were people with serious diseases like malaria coming in, and this was the only treatment that was available. So all of this I found really striking. A couple of years later, I traveled in Pakistan, mainly in Karachi, because that was the hotspot for polio there. Now, this is a suburb of Karachi called Gadap. And this was part of the natural landscape, if you will. So basically, it is raw, untreated sewage going down. And actually up here, before I took the photographs, once more, there were kids playing around. By the time I got my camera, they had sort of run off somewhere else, but this is what we saw. And in Kano, we visited, or rather the UNICEF team with me trailing behind, visited the hut of this man. He was a local farmer. Now, the previous day, there had been a polio vaccination campaign in this village, and he had many children. He refused to vaccinate all of them. So the UNICEF communication team had come back to try and reason with him, saying, please get your children vaccinated. So this guy saw all these strangers sitting in his hut, and finally he said, okay, I'll get them vaccinated. Later, I was chatting with him later through an interpreter, and then he exploded. This guy said, why? What is this polio all the time? He said when one of his kids falls sick, he needs to carry him up to the nearest road, wait for a bus and go and see a private practitioner in town, costs a lot of money, take a bus back, buy medicine, it's a big deal. And children there were falling sick all the time. Instead, you had this disease polio, which nobody had seen because, as I had said, Nigeria at that time perhaps had about 100, 150 cases. And it was number one in terms of polio cases in the world. But this was just 150 cases. In the background of this ocean of other infectious diseases, as well as other non-infectious conditions that children were facing. So, and nobody had actually seen, people had seen cases of polio, but only if it happened in your village. Otherwise, you didn't even know what this was. So he said, what is this polio? Why don't they give me something why don't they give us something that we need? Right? We don't have any healthcare. And then these people drive up in big SUVs and give this medicine free. And this is the only medicine that we get free is polio vaccine. And he said, there must be something wrong. And it was in this backdrop also that rumors started about the polio vaccine itself, saying that this was a Western plot. And this was just, it's the 20th anniversary of 9/11. It was a few days. So it's probably apt to say that the post 9/11, the rumors started spreading in Nigeria that polio vaccination was the West's revenge for the 9/11 attacks. And they were giving this polio vaccine to make all their little children, both the boys and the girls, sterile so that the Muslim population would die out. Right? And so you can see the landscape within which these beliefs and these rumors take root and how it affects behavior. And actually from this guy's perspective, it actually was rational. What I want, nobody gives me. Instead, these foreigners come with all and give me this free medicine for a disease I've never seen. What's going on? This was taken in Gadap. You saw the sewage. The sewage actually is at the end of the road on which this gentleman lives, right? It's a long gully, and at the end of it was the river that you saw. So once more, I was walking or trailing along, to be more accurate, behind a group of WHO officials, as well as the local city government, the local health officials, the local Karachi Health Department. And they were trying to inspect the polio program. And suddenly this old man, most people had closed their doors, they didn't want to talk to anybody. This guy's door opened and he came charging out and he said, "Please, my wife is sick. Will you help to get her to a hospital? I don't know how to take her. Right? She can't walk. I'm an old man. I can't take her either." And the local government officials, the health officials, they listened to him and said, "Sorry, we're here for polio program. Somebody will come and help you later." And they walked on, right? And I found that really both moving and striking because it symbolized to me something that was seriously wrong with globally led disease eradication efforts. So what were these observations? First of all, a huge gap existed between what the polio program was delivering and what people wanted. Without basic water, sanitation, and addressing some of the main causes of morbidity among children, diarrheal disease and malaria, what was really being achieved by putting so much effort and resources into eradicating a single disease? Now, this is a horrible disease. It crippled people for life. But if you put it against this context, questions do arise. The other thing, of course, that people were fatigued by multiple vaccine rounds. So the children were being repeatedly vaccinated. And this was an issue with the oral polio vaccine, which I will come to a little later. The other thing, polio, like all these global campaigns, were delivered as a separate special campaign, specially funded, specially run, specially directed, right? Apart from all, it stood apart from other routine health services because it got global funding, it had a lot of global visibility, if you will. You had global leaders saying polio must be eradicated. You had Bill Gates throwing in a lot of money behind it. Gates coming to Pakistan, meeting the Pakistani president and saying polio must be eradicated. Huge amount of visibility for this one disease. And so the question that I was left with, the question, to be honest, that I am still left with was, why was not public health delivering what the public wanted? Had there been any consultation between local communities before this global campaign was launched? And the answer, as you go back
Sorry, everyone. Looks like we lost Thomas again. I think his internet might have broken down again. We'll just hang in there for a few minutes. He'll probably just join in again. Thanks again. Hi, Thomas, you're muted. Thomas, you might have to unmute yourself.
Yeah, I have. Thanks. I've been trying. Okay, so I'm on data now, and I hope it works. And I'm getting to the end of it, and once the slides are over, I can actually put the video off. So once more, deep apologies. My internet is playing up today. I don't know when I was cut off, but basically I was talking about the weaknesses. The OPV, the oral polio vaccine, was a brilliant invention, if you will, but it had its weaknesses. It was far less effective in tropical parts of the world where infections from other enteroviruses were prevalent. Polio is an enterovirus.
Thomas, if I may, it cut off around at the end of that slide where you were talking about why was public health not directed towards what the public wanted.
Sorry. I was going on at great length about things which obviously nobody heard. All right, so
just some context. Yeah.
Okay, thanks very much. So I'm going to go back just to this last bullet point. Is that okay, Venkat?
Yeah, go ahead.
Yeah, okay. Yeah. So this was the question that still remains in my mind. Why was public health not delivering what the public wanted? Was there any consultation? And we saw from what happened in 1988 that there was absolutely no consultation. You know, the health ministers from all over the world just voted yes for polio eradication without really thinking through what this actually meant, whether they really needed this or not. The other problem was issues with the vaccine. Sabin's OPV was a brilliant invention, easy to administer, cheap, as safe as other childhood vaccines, and it achieved excellent results in many parts of the world. However, it had weaknesses. One, it was less effective in tropical parts of the world because where other enterovirus infections are common. And what happened, even in India, for example, because enteroviruses are so prevalent, these viruses have already infected the guts of children, and they are basically other enteroviruses attached to the receptors that the poliovirus or the poliovirus vaccine would normally attach to in order to reproduce and multiply. The vaccine was based, it was a live attenuated poliovirus, it was based on a live attenuated poliovirus. And in areas of poor hygiene and sanitation and low vaccine coverage, the vaccine virus could transmit between children. How did that happen? Sabin said that the big thing about my vaccine is that it follows the natural route of infection of the poliovirus itself, right? And what is the route of infection? The virus, it's a fecal oral transmission. The virus enters through the mouth, reproduces in the guts, is excreted, and then finds its way to other children, fresh hosts, right? Through contaminated water, lack of hygiene, whatever. So what Sabin said was that this is great because it follows a natural route of infection. And he said, this is also excellent because in areas of poor hygiene, the vaccine virus will actually be transmitted even to non-vaccinated children, right? And give them a degree of immunity, because if it's mixed in the water supply and so on, children will get it, and basically they will be getting multiple doses of this attenuated virus. Unfortunately, what has happened is that over long periods, if the vaccine virus keeps transmitting from host to host to host to host, it can, and it does, reacquire the mutations or the properties for neurovirulence, which were in a sense mutated out by Albert Sabin when he made the virus. So it reacquires neurovirulence. Now, scientists had warned of this problem since the 1960s and had urged that, that only there was another inactivated vaccine, and urged that this was a lot safer and only this vaccine really ought to be used. But the polio campaign kept using it. It was cheap and it was effective. And the argument, and this is a legitimate public health argument, was that the benefits of using this vaccine in terms of the numbers of children saved from paralysis outweighed the risk of paralysis that the vaccine itself caused. So if you look at it in terms of risk and benefit, the benefits outweighed the risks of the OPV. So, however, and this is the slide that I showed earlier, as you can see, these green dots really each.
Thomas, the slides are not showing. I think you set them off. You want to show the slides? Okay, which slide was the last one you saw? We've been only seeing your video because you said that you're on data, so we weren't sure if. All right, okay, so why don't I just continue then? Yeah, I leave it to you. I just want to let you know that. All right, okay, thanks. Yeah. Okay. And I'm going to go through quite fast now. So basically, if you remember the slide of cases as they are today, you could see these vaccine-derived poliovirus cases basically across the world. Well, not across the world, but across large swathes of Africa and in Afghanistan and Pakistan. On top of this all, the 1988 agreeing to polio eradication was a huge leap of optimism. And that's something that fascinated me. It tells you something about the human psyche, because the record eradication is not good. It is terrible. So over the last 100 years, global campaigns have been launched to eradicate yellow fever, malaria, dracunculiasis, I don't know how to pronounce it, guinea worm, hookworm, yaws, smallpox, and polio. Of these, only smallpox has been eradicated. Every other campaign has been wound up. The guinea worm campaign is still going on, but for a decade now, they say that we're close to achieving eradication, but it hasn't happened. Polio is still going on. For decades, they've been saying close to eradication, but sorry, I'm seeing there's a message from you. But all the other, after expenditures of large amounts of money, all the other campaigns were wound up. And the goal really for all these other diseases has not been eradication, but rather elimination or control. And elimination means bringing numbers to a low enough level so that they're no longer a significant public health program. And by that, you could, by that yardstick, you could argue that polio has been largely eliminated, and you could call this a success. However, the point of the matter was the aim was eradication. And the point of eradication is that you don't need to take any more, you can stop vaccination, right? And so it was worth spending all these billions of dollars, roughly it's $1 billion a year, on this program, this heavily focused single disease program, provided the payoff was that the virus ceased to exist and you no longer needed to incur the costs of immunizing children until the end of time, as long as humanity exists. But without that payoff, it's
basically you spent a lot of money that you need not have. And this polio program could easily have been merged or included with all the other routine immunization programs for children, but that didn't happen. So what went wrong? I'm going to wind up really quickly. With the earlier eradication campaigns, it was a combination of inadequate science and poor tools. In the case of malaria, the eradication strategy was based on using DDT to wipe out the Anopheles mosquitoes, which is the vector that carries the malarium plasmodium from human to human. And DDT, when it appeared, was this wonder. You know, it eliminated mosquitoes. It seemed to cause no harm to humans at all. And it was thought this is the way we will get rid of Anopheles. We will eradicate Anopheles mosquitoes using DDT and thereby eliminate malaria. It didn't work because clearly resistant strains of mosquitoes appeared. Evolution was at work. Secondly, the effect of DDT on human health and the environment became known, different kinds, and clearly DDT was not something that could be used much longer. So the WHO gave up that campaign. Yellow fever eradication 2 was based on eliminating the Aedes mosquito, which is the vector for the yellow fever virus, using insecticides and so on. But this was given up when suddenly the discovery was made that yellow fever had 2 cycles of transmission. One is in urban areas, and then there's a separate rural or sylvatic cycle of transmission for the yellow fever virus, where it is hosted in monkeys, which is their natural host. And so people going into jungles could get infected by the jungle form of yellow fever, come back, infect communities, and so on and so forth. So eradication clearly was not possible. It was given up. And each of these diseases, there has been a similar thing, except smallpox. Smallpox succeeded, and this is a huge, huge achievement. Not having to be vaccinated against smallpox, not having to face the danger of having this disfiguring disease, or your children facing this disfiguring disease. It's a huge, huge achievement. But many, including those who were involved in the smallpox campaign, thought that this was an exception based on luck as much as anything else. And D.A. Henderson, who was leader of the smallpox eradication campaign at the WHO, later said, it was only the grace of God that events happened as they did and allowed a successful execution of the smallpox program. Basically, it was luck. We managed it. Thank goodness we managed it, but we don't know how we did it. And this comes really to the question that is in my mind, and I want to really share with all of you. And that is eradication a feasible strategy for protecting the world against disease? It's an audacious strategy. It's an ambitious strategy. It says a lot about the confidence of science and of human beings in their ability to shape the natural world to their liking, and their confidence in being able to conceive of the right kind of tools to achieve this. But is it feasible? So there's public health is, as many of you will know, I mean, it's not a religion, but let's assume it is a religion. If it was as a religion, it's a religion with many sects and many cults and many divisions within it. And many in public health believe that merely focusing on the pathogen, which is what eradicationists do, without looking at the wider social, economic, and ecological background within which diseases flourish, is not a feasible strategy. And they argue that disease is much more than the pathogen or the individual who is infected. They say a disease is a combination of infection plus a whole variety, a whole number of circumstances that allow this infection to happen and for the infection to be manifested as disease. The René Dubos, the French-Canadian microbiologist who pioneered the idea of disease ecology and whose ideas I find fascinating, said that it was important not to focus on the living things themselves, but rather on their interrelationships and on their interplay with surroundings and events. Similarly, others have focused on the social and economic roots of disease, a method pioneered in the 19th century by Rudolf Virchow, the German pathologist, physician, who pioneered what is now known as social medicine. And Virchow was sent to a poor part of Germany, Silesia, which had a Polish-speaking minority. It was extremely poor, to investigate an outbreak of tuberculosis there. So he went there, he studied the matter, and he came and wrote a report. The report did not mention the disease. Instead, it focused on the wretched living conditions that people were living in. Poor sanitation, poor hygiene, cramped spaces. And the message was clear. This is what is causing the disease, right? And so you've got this whole school of social medicine itself, which focuses on the conditions within which the interaction or the relationship between man and pathogen erupts into disease and transmits in human communities. So I'll leave, or rather I'll end with a question. Would the best way to deal with polio have been to deal with the conditions within which polio flourishes? And the photographs that I left you with, those really are the conditions in which polio flourishes. So this really is my question. So really, this is a story about the strategy of eradication. What are the factors that lead to the interaction between man, to an interaction between man and microbe erupt into disease, if you will, and spread among disease, be recognized as a disease, and what is the best way to deal with this and assure human health? Sorry, I'm trying to get out of full screen right now and hopefully get the video back. Yeah, okay, so I'm on video now. I hope you can all see and you heard me as well. Once more, deep apologies for the poor connection. I think it's a continuing poor connection, but happy to answer questions or participate in any discussion.
Thanks, Thomas. Thank you so much.
Not at all. I'm wondering,
can
I switch my video off given the low bandwidth? Is that all right? Maybe that would be easier.
Yeah,
oh, is
sure.
it okay?
I mean, it's
okay, let's continue this. Let's continue this way. As long as this works, it works. Yeah. Okay.
No, thanks so much. To those of you listening here and on YouTube, do feel free to start putting in your questions in any of the different chat or Q&A forums that you see. And thanks so much for this conversation, Thomas. I just wanted to start off with something that, this question that you raised somewhere in the middle or maybe 2/3 the way into your talk, which is the question of public health and communities and how public health sometimes is not, I think the way you phrased it was, why is public health not listening to a community before it makes a decision? And I was wondering if you could sort of touch upon that a little bit more, independent of a disease, just, historically, other communities where this has happened, other instances where the process of public health is sort of more ground up rather than global. I mean, can you just talk a little bit more about this?
Yeah,
or is
absolutely.
It really...
it is fascinating. Now, among all the medical sciences, public health is actually supposed to be the most democratic and egalitarian. And medical science in general still is a very top-down profession. I mean, you've got experts, sources of authority, who give instructions to the public. But this is changing. both in clinical medicine as well as public health. Public health is supposed to be the most egalitarian because its aims are egalitarian, to ensure the health of entire communities, regardless of who you are. This is changing, but very, very slowly, because there still is, we live in a very hierarchical world, and there are huge differences in power between those who, so-called the subjects, if you will, of public health advice, and those who are actually giving advice. But there are really interesting ways in which this is being broken. I would like actually to, there was an article recently in the India Forum about a group that is working with Adivasis in Chamarajanagar, isolated Adivasi tribal communities. And this was during the peak of the last wave. COVID had reached these communities, and there was a young man who tested positive, and one of his relatives died. So the local district authorities and the Jilla Parishad people wanted to get him out of the village and into a COVID isolation center in town, right? And he refused. So they brought in the local teacher, people came in, they tried to explain to him, this is what is best for you. And then the officials tried to threaten him, saying that you have no choice, you have to do this. Both he and the community said, thanks whoever is sharing it. And both he and the community said, this is not going to happen. But through a process of dialogue, they arrived and the community actually came up with this solution. Why don't we use the local school in our village as a COVID care center for all our Adivasi tribals, in all the surrounding hamlets? They can all come here, right? We will cook for them. They will be surrounded by their community. We will look after them. And that was a solution which was workable. So it was quickly repurposed. That became the community, the containment center. So the goals of public health were achieved because those who were infected were being isolated, so transmission was reduced. The goals of the community and individuals were also, because they were deeply suspicious of being sent to towns. Who knows what's going to happen? Maybe what the fate that befalls me there will be worse than falling ill with COVID, right? So their needs were also met. Their demand, and so, but the important thing was that this is a solution that really came through negotiation and really an idea that came from the people sitting there. So it was explained to them, we need to isolate you. So they said, okay, how about you isolate us here, right? And so this is a fascinating example of what can happen and what public health should be about in terms of empowering people and giving people agency in terms of determining how their health is going to be protected. I mean, and all experts really should be doing is giving them information and options, saying this is why we want you to isolate yourself so that you won't infect other people, right? And then the thing is, okay, but I need to go and earn a living. So you need a solution to that. You can't just lock the door, or you can't hammer tin sheets around the door. And so it is through a process of negotiation that disease can be fought. And in the context of COVID, at the end of the day, a pandemic that has been lasting for 18 months and is likely to continue into the new year, into the next year, is going to be fought by communities and individuals, because there's only so much that any government can actually do. And so really, I'm really hopeful. I'm an eternal optimist. Like the people who voted for polio eradication, I guess I am an optimist too. I do believe that maybe it'll be possible we will see new forms of community engagement in public health as a result, one amongst the many changes that we're going to see as a result of this pandemic. Sorry, that was a long answer to a short question.
Thanks, Thomas. Thank you so much. There's a range of questions in the chat. I'm just going to pick on Aditi's. I think you've sort of addressed this in your comment, but Aditi asked a question, and I quote, just for my understanding, are you making a case for public health alongside disease eradication or instead of disease eradication? And I think you've kind of alluded to this, but maybe you just want to quickly follow that one up.
I think that really is an important issue. I think in terms of strategy, if polio does succeed, when it does succeed, measles is likely to be the next candidate for eradication because it's technically eradicable, you're already there. But I don't think anyone is thinking of having a polio type campaign to eradicate measles. Disease, let's look at disease from the point of view of a human being or from a child, right? It is no point protecting a child from polio if by age 5 it has died of acute diarrheal disease. So we need to protect individuals. You need a spectrum of protections, right? So you need integrated solutions. So I would say instead of targeting individual diseases for eradication, we need measures to tackle all diseases, which is, in a sense, is what routine childhood immunization does. I mean, when you take your child for its routine shots, it's getting shots against 3, 4, 5 diseases, right? And this is really what we should be doing. We should also be tackling some of the social, environmental determinants of disease, whether it is pollution, whether it is poverty, whether it is lack of access to nutrition. So rather than focusing on each disease by itself, we should really look at the whole spectrum of threats to disease. The process may take longer. It may not be as eye-catching. We will wipe polio off spaceship Earth is really a very, very eye-catching slogan, right? And it's something that will get people eliminated. But saying that we will eliminate neonatal tetanus by the year 2000 is not going to get that same kind of public enthusiasm, though in public health terms, it'll probably achieve the same in terms of saving lives and, more important, protecting children from illness. So I hope I've answered that question. So I think I'm against individual disease, and I think all diseases need to be tackled, but we need to do it really in a holistic way, which takes into account not merely the pathogen, but also the circumstances and the situation which allow these pathogens to transmit and create disease.
Thank you. I see that Manasvi has 4 questions. So instead of before I go into those, I want to sort of call on Tanisha if she can unmute herself and just ask her question, just so we have some varied voices. So Tanisha, if you can, could you go ahead and ask your question?
Sure. Hi, Thomas.
Yeah, if you could just speak a little louder, Tanisha, if you could.
Hello, is this better?
Tanisha, we can't hear you, I think. Or is it just me?
Yeah, I can hear you very faintly, Tanisha. If Thomas can't hear, then I'm happy to relay the question.
Yeah, I'm afraid I can't. Is it already in the chat? I can take it straight from. Is it?
Yeah, so I'll just take it. Tanisha, if you don't mind, I'm just going to read it out for Thomas. Sorry about this. So Thomas, the question from Tanisha was, again, you probably alluded to this. How can large international health organizations actually look out for social health care at a local level? And I think this, it's a huge issue.
Yeah, so it's basically the same thing. Now, I want, all the large international organizations are already aware of this problem at one level, right? And the need really to, in fact, they started with the whole Alma Ata their primary health movement, the need really to connect with community needs. And unfortunately, the way international global disease programs are funded makes it very difficult to have a holistic approach. Because what happens is a donor X says, I think measles is the most serious issue facing children. And I will give you X billion dollars every year if you will eradicate measles. So there is no organization in the world that is going to say, please don't give me X billion, right? Or no, I'm going to take a holistic approach. No, they will take the money. And they'll say, at least we can eliminate one disease, at least we've got money for that. Why do donors and donor governments do this? Because it's easier for them to justify. Philanthropies find it a lot easier, but in terms of governments and government aid budgets, it's much easier to justify this to your own public by saying, we have helped to eliminate X disease in Y country, rather than saying that we have helped to strengthen health systems. So on the one hand, everybody knows that this is a problem, that we need to move away from funding single diseases. We need to empower communities. All the documents, all the resolutions coming out of every global organization says this. A huge issue is the way these programs are funded. And donors, I mean, we can't put the blame only on donors, but donors have their own compunctions, especially governments, which need to justify all of this expenditure to their public. And it's a lot easier for them really to say that we have helped to do this one big flagship project. And people in this country are so much happier because they don't have this disease anymore. I think these are some of the issues. And your question really is, so this is the problem. And the question is really, what can our international health organizations do to reach down to local levels? On the one hand, I think we need to sensitize donors, but more important, we also need to sensitize governments, because international organizations deal with national governments, right? An international organization cannot go down to a hamlet in Mysore or Chamarajanagar or wherever and start doing work there. Everything comes through governments because these are intergovernmental organizations. So the process of reform, if you will, the process of democratizing public health and making it responsive to communities really needs to start in communities, in groups like this, perhaps, in the political discourse of countries themselves, saying this is what we want. This is what public health should be. So I think these are some of the changes that need to happen.
Thanks, Thomas. Thank you. So while, I think you sort of briefly touched upon the commerce of disease eradication. So I thought I'll just pick a few questions that have come in the chat, and I'll just try and club some of these together. So one which came from YouTube from MD Madhusudan is, and I quote, could you comment on the commercial facets of the production and distribution of the oral polio vaccine and where the gains are actually accruing? And there was another one earlier from Manasvi, which is perhaps maybe more focused in its scope, which is how much does a country like India really spend per year on immunizing against polio? Are these numbers that you might remember, or you can just point to references that someone can look at? So just a couple of questions, and then I want to switch direction to some sort of a philosophical angle towards the science.
Okay, so I think the first question really was in terms of basically the business of oral polio vaccine, to put it crudely. Is that right? I mean, who's sort of making money on this? Did I get that question right?
I think that's where it's headed. The person's on YouTube, so it's going to be hard for us to get the feedback. Yeah.
Okay, so OPV is not a great money spinner. So what happened was Albert Sabin developed it, and he gave all the rights to WHO, which in turn allows manufacturers to manufacture this. OPV is not a great money spinner for anybody, right? Simple vaccine, relatively cheap. And OPV, oral polio vaccine, is being phased out. It has been phased out for some years, and we have the polio immunization now is going to use an injected, inactivated vaccine of the kind that was actually developed by Jonas Salk, and that was really the first polio vaccine. So in this, I don't think money does not play a great role, right? And similarly, in terms of how much do polio immunization campaigns cost in India today. I really don't have the figure offhand, but it is not a huge amount. You know, in terms of the wide spectrum of issues of other public health programs that are running, national immunization campaigns are not big. And in fact, globally as well, over the last 2 years, I mean, post-COVID, I don't know how many immunization campaigns have actually been run, because clearly it is not practical. It's not practical, first of all. We've stopped door-to-door campaigns, but even the daily, I mean, the sort of mass campaigns that happen on certain times of the year, if you will, those I think have largely come to a halt, though I'm not 100% sure, because, and actually this brings us back to one more issue, I think, not just with polio, but with all child. This is one of the unfortunate effects, many unfortunate effects of the pandemic, is that all routine immunizations have basically come to a standstill. Treatment for other illnesses also have become extremely difficult, because the globally health services have been focused now and stretched trying to do just one thing, and that is respond to the pandemic. Obviously it's opening up now, but it'll take a while. So COVID, I think, has had a knock-on effect both on polio immunization, all routine immunizations, and plus other programs, including routine checkups for cancer, tuberculosis. Tuberculosis has been badly affected, I understand. I don't have the figures with me, because it requires constant follow-up. It requires constant attention to people having the medication and so on and so forth, and that clearly hasn't been happening. So I don't think, to sum up both of these questions, money here is not the biggest issue in terms of polio at any rate. It's a whole variety of other sort of social issues, I think. Issues from the point of view of demand, of community demand for polio eradication.
All right, thank you. There are a couple of other questions that Manasvi had raised in the chat, and I'll just club them as well. These are maybe quick ones. I think you alluded to what the current immunization status is, Thomas, but since there is this risk of being reintroduced by traveling individuals, is there any sense of which countries in the world are still continuing to have an immunization program against polio? Is there a sense of that? And coupled to that, perhaps, is a question about what happened in India. Why did the sort of the re-virulence not happen here the way it happened in other countries? So if you could just sort of talk about these two.
Yeah, so let me begin with the India story, which truly I think is a huge achievement, also a miracle of some kind. So there were vaccine-derived cases as well. Now, but the polio immunization, it started off really slowly. But in the last stages, I think the last case of polio in India was 2011, December 2011, right? And this was a little girl in Calcutta, in Howrah, which is the last case of paralytic polio in India. So the 2000s, 2004, 2005, 6, 7, 8 were terrible for polio. And India had the largest burden of cases. And the disease really was skiving through UP and Bihar. These were the two main sort of epicenters of polio. But the then government really decided, both the Prime Minister as well as the respective state governments really got together, got their act together. The entire health machinery of these states, plus a huge amount from the central government, plus resources globally, was put into carrying out intensive vaccination campaigns. So you had children who were being vaccinated every 3-4 months, so 4 to 5 times a year. And why? Because OPV was really not that effective. It needed to be given not just twice a year, which was what was thought initially, but multiple times, because it took that much longer for the virus vaccine to cause an infection, a significant infection, and to create antibodies in the body. So it was an immense effort. And it was an exhausting effort as well, because right down from your ASHA worker in your primary healthcare center to, the top levels of the central and healthcare workers there, they were focused just on one thing: delivering these immunization campaigns. These campaigns were 1- and 2-day campaigns, but to plan for a 1-day campaign takes the best part of a month. Getting vaccine supplies, getting personnel, deciding who's going to go there, documenting the whole process. It's an enormous process. And so that was a great achievement, and they pulled off. They got vaccination coverage up to such a high level that the virus really had no space left. And they achieved this by multiple doses of oral polio vaccine, again and again and again, getting the same kids immunized again and again and again and again, and missing fewer and fewer numbers of children with each round, until there was enough collective immunity, or to use a term that is heard very often but misused, I think, herd immunity. So basically, the polio virus had no place to reproduce anymore. And that was how that was achieved. So huge effort. If it had not happened by 2011, I don't think India could have sustained this. And 2012, 2013, if there were still cases, I don't think it would have been possible. I think the Indian government would have no choice but really to pull back and use its, and sort of send resources back to other disease programs. They'd all been sucked to into this one program. Sorry, did I answer that? Yeah.
Yeah, I think there was just this, these other questions around which other places around the world where the immunization program is still active, given...
Oh, yeah, absolutely. Yes. So polio immunization at the moment, because of COVID, is not happening. Afghanistan, nobody knows what's happening there. Pakistan, they haven't really been able to roll out immunization programs at all. West Africa, by the way, and Central Africa has also had Ebola outbreaks in between, right? And so immunization basically has come to a standstill. And this is really dangerous because it does mean that the virus now has been given space to expand, to retransmit, to colonize new guts, if you will, and keep transmitting. So what the impact of COVID-19 is going to be on polio is really, it is not going to be good. The question really is, how bad is it going to be? And once you have large explosions of disease in different areas, it's just a matter of time that this spreads. In a sense, we're good. This is a good time also, a fortunate time that international travel is barely existing, right? So whatever is happening is contained in fairly small geographical areas, but that's not going to last forever. And so I'm not at all optimistic about what's going to happen, in the post-COVID period from 2022 onwards, perhaps.
Thanks. In the interest of time, we'll just maybe jump to this one question from Satyajit Mayer, who I think had to leave, Thomas, but he shared this question. I think it's a good note to perhaps wrap our conversation today. And I quote, ecological niches for disease is not quite about looking at the human reservoir. Natural reservoirs are also to be considered, of course. And so it's not just the health of the human, but also of environments that one needs to be focusing on. And he asked, what are your thoughts? And I suppose maybe the addition to that I'll sort of add is to see how this fits within the framework of what is called public health. Just curious to know if you have any thoughts on that.
Yeah. So, there's this the other concept now, which is gaining power, it's been around for a while, is the idea of One Health, right? Because so many infectious diseases are zoonoses. They're transmitted, they're zoonotic diseases that have passed on to human beings. So for the last, since about 2000, at least since 2003, post-SARS, 2003 onwards, there has been this emphasis on One Health. And that is looking at both animal health and human health together. right? Which is difficult because once more, you've got two completely separate streams of people looking after animal health and human health. But at the international level, there is this huge move. And I hope actually COVID accelerates that, really to look at this much more holistically. And also to look at the whole issue of commercial farming, of poultry, of ducks, poultry, sheep, chicken, cattle, all of this. Commercial in the sense of industrial farming. Of the kind that happens in the West and increasingly here as well, I think, because once more, once a virus is introduced into a population like this, it spreads rapidly, right? And it's got chances to evolve, to change, to take new forms, because one of the interesting things about COVID, of course, was being the infection of mink. Mink are bred in Netherlands and Denmark for fur, in commercial mink farms. And one of the alarming things that happened was that humans had infected mink. SARS-CoV-2 transmitted rapidly amongst mink and also acquired new variants amongst mink, none of which were concerning to humans at that point of time, but could have been, which is why all the mink farms and all the animals were culled very rapidly. But you can see there's a constant churning between the animal world and the human world and back. It is not just animals infecting humans, but humans are also infecting animals. So clearly, when we talk about an ecological approach, we are talking really about the entire the environment which we have created and which we live and which we affect with every action in our day-to-day life in some way or the other. And this also comes in or joins the whole the climate agenda as well, right? And the impact of rising climate or rising temperatures and changing weather patterns on disease transmission is also very serious. As temperatures rise, for example, malaria has started to reappear in parts of Southern Europe. With rising temperatures and so on. So clearly, the relationship between man and the pathogen is just one small part of a far wider, far richer network of interactions, which we need to understand and which we need to address as well.
Thank you. That's a lovely, good reflective note to wrap our conversation today, Thomas. So thank you so much to you and to all the audience members who shared their questions. I had many more around the topic of risk, but I'm just going to save that for a conversation with you when we can meet in person, because I've been fascinated by this association of risk and public health, and what is the risk appetite for large organizations that tend to move slowly. But anyway, so thank you again to everyone. We will conclude our live session of the 41st edition of the public lecture. If I could request the hosts, Vaibhavi in the Bangalore Life Science Cluster, to perhaps stop the YouTube and the recording. And for those of you still around, we will see you in October to, we'll see in October to pivot to looking at histories of urban spaces, so a very different kind of a conversation. Yeah, that's it.
Okay, thank you very much. And apologies once more for the terrible, the technological issues, which I'm glad, and I think so many of you were patient enough to sit through all of this. So thank you very much. And thank you, Venkat, for the invitation.
Oh, thank you. It comes with the territory. So I do hope to see you in person soon. So thanks again.
Take care. Bye-bye.